not on any. Coming to the personal history, he gives his history like appetite is decreased and sleep is normal. Bowel habits has altered, but bladder habits are normal. He takes a mixed diet, and habits include he's a chronic smoker. That is one cigarette pack per day since last 25 years. Stopped 2 weeks back, and occasional alcohol intake. That is roughly 1 to 2 per month. And married, and he has 2 children. Family history, he gives history of his father being diagnosed with colon cancer at the age of 65 years. Coming to the general examination, patient was examined in a well-lit room.
Can you just stop there, Anthony? Yes. And yes, would you just in concise tell us what your history was? Just make it concise and in simple 5 lines.
Sir, he's a 62-year-old male who with no comorbidities, with a family history of CA colon in his father, diagnosed at 65 years of age, who presented to us with complaint of vague abdominal pain since last 3 months and altered bowel habits last 2 months with associated history of loss of appetite and weight.
Okay. How significant was the weight loss?
Sir, actually, the weight loss was not documented, but he gives a history like there is recent loosening of the clothes that he has used before.
Okay. What is the significance of weight loss in BI malignancy?
So in GA malignancies, it may present with significant weight loss. And for many malignancies, actually, it's a bad factor, like a prognostic factor also.
Okay. Weight loss is a bad prognostic factor. Would you be able to define what a prognostic factor is and what a predictive factor is?
Sir, prognostic factor, the predictive factor, it like decides the treatment. It has it has influence on the treatment, and the prognostic factor, the prognostic factor is the.
Okay, it's okay. Take a note down so that you go back and read. These are absolute basics which any examiner is going to catch you on. And if you fumble here, your discussion would not go up to the high-end chemotherapy and the latest immunotherapy, which probably you have read very well and come. It will not reach there. You shouldn't fumble here. That is the basic point. Okay.
Okay.
Simple things like why should weight loss be a prognostic factor? What is a predictive factor? You should be able to say what it is and then at least give 2 examples in one breath. That's what makes a difference. All right.
Okay.
Okay. So you said you have a 65-year-old male, and this gentleman has a family history. How relevant is a family history in a patient with bowel symptoms and a family history of a father having colon cancer?
This patient
what are you trying to suggest?
So this patient gives a history of his first degree relative with the CA colon. So he is having increased risk like for developing CA colon. That's 2 times the risk for developing CA colon.
Come again. So you said somebody has father at 65 years of age with CA colon. That basically means he also has CA colon. So tomorrow you have another patient who has got a renal cell carcinoma. His son will also have renal cell carcinoma. Somebody has liver cancer. His son will also have liver cancer. Is that how you are describing it, or are there any specific associations that you know of which tells you that there is a familial trend for malignancy? You did say father had CA colon. What is the syndrome which is associated with CA colon?
Sorry, sir.
what is the syndrome that is associated with CA colon?
So syndromes associated with CA colon includes FAP, familial adenomatous polyposis, Lynch syndrome.
Correct. Correct. So are there other associated diseases along with this, which suggests that it could be a Lynch syndrome or a FAP or a HNPCC or XYZ? It is always better to bring in some of the negative histories. Like, for example, if you have Lynch syndrome, what are the other diseases, other malignancies which are associated with Lynch syndrome?
With Lynch syndrome, like the other associated malignancies include endometrium, ovary, kidney, ureter, bladder, colon.
Everything in the abdomen is over.
Yes, sir.
You have named every organ in the abdomen. So it's always like you said, endometrium. It's always good when you're describing your significant family history to say out the negative family history too. So you say 65-year-old father had CA of colon, but at the same time, if you say it in another breath, there is no history of the endometrium, there is no history of pancreatic cancer, there is no history of this. At least your examiner gets the idea that you have already thought about a particular syndrome and he doesn't come back asking you the same question, right? Your
Yes, sir.
intention is to make sure your examiners don't ask you questions. Did you get what I said?
Yes, sir.
All right. Carry on. Go on to general examination. Dr. Sanju, anything that you want to add or ask?
Anthony, so you mentioned about some of the very relevant symptoms. So, do you think you can come to a kind of differential diagnosis based on this, the location of the tumor, etc.? If at all you are suspecting a malignancy there, what will be your differential diagnosis at the end of history with this? The complaints what patient has mentioned.
Sir, with these complaints, I will suspect a GI malignancy.
That's very vague.
Uh,
So what is the most important history here? You told about abdominal pain, altered bowel,
yes,
loss of appetite, loss of weight. So which one will be most significant here of the three?
Sir, altered bowel habits.
Exactly. So what does that point towards?
So towards colon.
Colon. So now tell me, which side of colon are you suspecting in a patient with altered bowel habits?
Sir, usually it is left-sided.
Exactly. But you told the patient is complaining of pain in the right side.
Yes, sir. Yes.
Now, how to? So that is something confusing. So right side pain. So which side is usually abdominal pain means? What would be the usual location of tumor? Left to right is more common.
Sir, left-sided.
Left side. So we are actually suspecting a left-sided tumor
Yes,
here. Okay.
Yes, sir. Hello.
Anybody with a family member affected with colon cancer probably will be at a high risk, as you rightly mentioned. So what is again important here? What would be if somebody is having a family member with colon cancer? What will be one thing which will be giving you a clue towards one of the syndromic association, other than the type of tumor? What was the age of the age of his father when he developed colon cancer?
Sir, 65 years.
Exactly. So this patient is 51. So anybody who is young patient. So how do you define a young onset colon cancer? What is the age cutoff?
So less than 40.
Okay. Even a 50. Okay. So he is 51, but still we will consider him as as a young patient with colon cancer. So suppose the young patient with colon cancer, 65-year-old, do you think this patient will be fitting in towards a possibility of Lynch? Only if you think like that, you will ask for those important negative histories what Wesley rightly mentioned. Not sure. Okay, so read about Lynch syndrome. Okay, carry on. Let's not waste time here. Basically, we'll go forward,
yeah,
right?
Go ahead.
Yeah.
Go ahead. Just a passing mention. When do you consider a family history more important? Somebody who is 65, 70, would you consider a family history, or would you have somebody who is younger? So generally, when you have a patient who is less than 50, is when you consider it a very important thing. But if you have somebody at 70, but here probably it makes sense because you have first degree relative who is affected. He has come 10 years before his father's age with similar sort of symptom and disease. So probably it's worth visiting. So do read up family history and how do we go about assessing it, and what are the Lynch alone is not the one. There are plenty of other. You did mention FAP, but there are plenty of others. So please go and read that. All right, let's go on.
So, coming to the general examination, the patient was examined in a well-lit room with consent after ensuring adequate privacy. He was conscious, cooperative, and well-oriented to time, place, and person. He was moderately built and nourished, had an ECOG performance status of 1, and height 170 centimeter, weight 65 kg, had a BMI of 22.49 kg per meter squared, and body surface area 1.75 meter squared. On examination, mild pallor was there. But there was no icterus, cyanosis, or clubbing, lymphadenopathy, or edema. Skin, hair, and nail were normal.
Carry on.
Vitals, he was febrile, pulse of 88 beats per minute, regular rhythm, normal volume and character. All peripheral pulsations felt equally and bilaterally. BP 130 by 80 in right upper limb at sitting position. Respiratory rate of 20 per minute, regular rhythm, and is of thoraco-abdominal type. With all the from the history, as we are suspecting an abdominal pathology, I'm concentrating more on abdominal examination. Coming to the abdominal examination, inspection, the abdomen is flat, umbilicus central and inverted. All quadrants move equally with respiration. No visible lump or fullness in any of the quadrants. Skin was normal, no engorged veins. There was no, in palpation, there was no local rise in temperature or tenderness in any of the quadrants. But a 6 into 5 centimeter ovoid, non-tender, mobile mass with well-defined borders and irregular surface, firm in consistency, non-pulsatile in right lumbar region that doesn't move with respiration was felt. It was non-ballotable, becomes less prominent on raising the lower limbs. There was no hepatosplenomegaly or any other extra mass palpable. Percussion, a dull note over the lump was noted, no shifting dullness, and upper border of the liver percussed in right fifth intercostal space. Liver span was 14 centimeter. Liver dullness was not continuous with the lump. Auscultation, normal bowel sounds were heard. PR rectal examination was done, which was normal only, and external genitalia was normal. And then systemic examination of other systems was done. Respiratory system, trachea midline, equal chest expansion. There was no clear breath sounds, no intercostal retractions, and serious normal heart sounds, no murmur. Neurological examination was normal limit. Skull and spine was also normal. So to summarize, a 51-year-old male, chronic smoker and alcoholic, no comorbidities, with a family history of CA colon in father, with complaint of vague abdominal pain since last 3 months and altered bowel habit since 2 months, with associated loss of appetite and loss of weight. And an examination revealed a mild pallor and a palpable mass in right lumbar region.
Okay, now you've reached the summary of it. You would probably have made a final thought in your mind as to what is the diagnosis, right? So
yes,
could you spell out your differentials that you have right now in mind?
So some of the differentials that come to my mind on taking history and examining the patient, like it may be a lump arising from the colon, or it may be a lump arising from the kidney or adrenal, or it may be a mass arising from the retroperitoneum.
You have all those differentials in mind after your clinical examination. I think you've described everything in detail in the clinical exam. And now saying something arising from the colon, from the adrenal, from the retroperitoneum, from the kidney. I think you should have probably ruled out half of these things in your clinical examination. So what have you ruled out?
Sir, renal mass I have ruled out.
Yeah, how did you rule that out? Because I asked you for a differential and you're giving me all these differential post your examination, which basically means you're still considering all these things.
Sir, so in differential diagnosis, I should rule out differential diagnosis.
Okay. When you're asked a differential diagnosis at the end of clinical examination, you're supposed to come back with a diagnosis which is almost as close as you can get with a clinical history taken. Okay, we are not expecting it could be this, it could be that, because you've got an opportunity to do your history and your general physical examination and a detailed clinical examination. Systemic examination is over. So now you should tell me what it is, right? So since you said it, how would you rule out a kidney? You didn't say anything about kidney examination in your clinical examination. How would you rule out?
Sir, it was non-ballotable.
Okay. So you did not mention that. You did mention about percussion. So if you're still keeping kidney as a differential now, that basically means that you did not look for it in your clinical examination. Ballotability is something that you could have said and gotten off the kidney out of the picture. You said adrenal. How do you figure out adrenal? Very difficult. I have still not been able to figure out adrenal based on a clinical examination unless until it's a huge mass, which rarely happens. What is the other thing you said? Colon and retroperitoneal mass. Retroperitoneal mass again. How do you make out? On the clinical examination as well as in the history, you would have specific history. Patients coming to you with diffuse back pain. You generally don't come in with an abdominal pain. Diffuse back pain, aching kind of a pain is what they come with. And you can feel a diffuse mass, but that too if it's a large mass, especially if you had history of TB and things like that. If you've ever seen a patient with psoas abscess, you would probably feel what you're talking about, the diffuse mass and the pain that they have in the back. So none of those things were there in your history. So I don't think entertaining those differential diagnoses at the end of your clinical examination and summary, when I'm going to ask you the next question of how you're going to proceed, really makes any sense. Okay. So if you think it is bowel, stick to bowel.
Yes, sir.
Do you understand what I'm saying?
Yes,
so
sir.
Don't go running around the whole of abdomen and start off with retroperitoneum and go to adrenal. It might get you into trouble. Do you understand what I'm saying?
Yes, sir.
Good. So now, having said that, can you boil down to saying it's just a pure bowel disease?
Yes, sir. With this scenario, I would suspect a neoplasm arising from the bowel. That's more towards colon.
Lumen of the bowel. Okay. Sanju?
Yeah, nothing, Wesley. So, how would you proceed from here, Anthony?
Sir,
what is your next investigation?
Sir, now my aim is to confirm my diagnosis. Hello?
We haven't come to a diagnosis. Yeah.
We haven't come to a diagnosis. You go ahead.
Sir, I would like to confirm a diagnosis and stage it, and then I would like to do some investigations to assess the fitness of the patient for the further treatment, and then some tests for prognostication. So I would like to do to assess the fitness of the patient. I would like to do CBC, bio, like RFT, LFT, and then to confirm the diagnosis, I would like to do a colonoscopy and biopsy. And then to stage, I would like to do a CT, thorax, abdomen, and pelvis with oral contrast and IV contrast.
What are you going to do first, Anthony? What are you going to do
exactly.
first? You're not going to start off doing all these things. What is the first thing?
So first thing, I would like to do a colonoscopy with biopsy.
With just your gut feeling that this is a bowel malignancy? You do a
Yes.
colonoscopy comes negative because you said there was a lump and there was a area of dullness. You could feel a 6 into 5 centimeter mass. For all you know, because you did not velote it, it might all be arising from the kidney. It's an exophytic mass from the kidney. You're in for trouble now. You got a colonoscopy done. It's an invasive procedure. Have you ever had a patient with colonoscopy? You know the steps of colonoscopy? What do you do the previous day of colonoscopy?
So preparation, bowel preparation.
Bowel preparation. You know how many times the patient goes to the washroom and stays in the washroom? You're supposed to have motions coming out as clear as water that he is drinking, right? You put a patient through so much of distress and a patient who's already got an abdominal pain, you're going to get into trouble. So is colonoscopy the first thing? These are all
you have a
questions.
mass. You have a mass palpable there, so it could be anything. Like Wesley told, can it be a kidney lesion, or say it's a huge lymph node sitting there? So if you don't have any clinical findings of any mass palpable, then probably what you told might be right. Now you have a huge lesion there. You have to characterize that lesion first and then do colonoscopy, or go ahead with colonoscopy first. How will you answer that?
So then I will do a imaging.
Okay. So what imaging will you ask for this patient?
So CT, thorax, abdomen, and pelvis with the IV contrast or oral contrast.
You want a CT thorax for what?
Why the CT thorax?
Sir, to rule out lung mets.
No,
we don't have a diagnosis.
So first we have to do a CT abdomen, right? So then let's see what is there, and then you can do a CT thorax at a later date if it turns out to be malignant. What if this is a idiopathic tuberculosis forming a mass, which can have exactly same symptoms: abdominal pain, altered bowel, etc., etc. Loss of appetite, loss of weight. You understood what we are talking?
Yes, sir.
So probably we have to ask for a cross-sectional imaging of the abdomen first. Okay. So
Okay,
do you have the reports with you?
Reports of the patient.
What sort of a CT would you ask for? What cross-sectional imaging? CT, because you can't just write CT abdomen and send the patient. What exactly is the order that you give? What does the radiologist need to know?
Sir, with oral and IV contrast. CT thorax and abdomen. CT thorax, CT,
okay,
sorry, CT abdomen.
Don't jump into thorax, just stay with the abdomen. Okay, it's always best to describe the entire scan. That's what the examiner is waiting to hear. When you say CT, it makes no sense. So you're going to say CT with contrast, without contrast, if contrast, then oral contrast, IV contrast, rectal contrast. There are plenty of things to tell your radiologist, because he's going to look for what you think is the problem. You don't just send a patient straight to the radiology department and say, okay, find out what it is and send the patient back. Then patients should all go to radiology department upfront. They shouldn't come to us, right? You already make a differential, so you need to tell them what you're thinking so that they specifically look for it. So you definitely need a contrast, or you don't need a contrast?
Definitely need a contrast, sir.
You definitely need a contrast. All right. So do you have the reports with you? Did
yes, sir.
get those reports? All right. Can you just show those pictures, or do you only have a report? Yeah, there's a cut there. All right. Tell us what you see.
Sir, there is irregular bowel wall thickening in the ascending colon.
Okay. So, all right. So again, in the examination, don't just jump and say ascending wall thickening. You say this is a CT of the abdomen. I'm probably being stupid in telling you these things because these are assumed to be absolute basics, but your old examiners will come and ask you the same stupid old questions. And they will expect you to say this is the CT of the abdomen taken at with contrast, without contrast, with oral contrast, with rectal contrast, whatever. And it is a section through level, whatever you think it is. What is the level at this? Can you mention what the level is? What do you get? What level is kidney with its hilum?
Sir, L2.
L2. Okay. So you would mention what the level is, and then you describe. I can see bowel, and there is contrast in the bowel. On the ascending colon, on the left side, I'm seeing on the right side, I'm seeing a thickening in the ascending colon. That's how you go about describing. You just don't say ascending colon thickening. Okay.
Yes,
keep that in mind. This is probably just taken from the report that you got in your hand, but that's how you describe. So if you're shown an X-ray, there's no harm in saying this is just X-ray, PA view, blah blah blah. If you're shown a PET CT or a bone scan, describe what you're seeing. Don't just jump, because the moment you jump, the examiner thinks you have already been told everything and you know the diagnosis and you know what it is. Then it gets twisted. All right. Okay. So here you see a CT of the abdomen at the level of renal hilum with ascending colon showing thickness. Is that what it is?
Yes, sir.
Okay. Can you see any lymph nodes there?
In this section, no, sir.
Okay. When you see a bowel wall with thickening, what else do you look in the periphery of the bowel?
Bowel lumen, if it is obstructed.
One, lumen is obstructed. Second,
Then if any perforation is there.
Perforation is there. Okay. What would you see if there is a perforation? You would see air, free air in the abdomen. Okay. What else?
Any, like fistula.
Fistula. No. Okay. If there are two bowel loops together, it's very difficult to make out. I find it difficult anyway. What
If
else?
there is any like abscess, pericolonic abscess.
Okay. Pericolonic abscess. Pericolonic fat infiltration.
Yes, sir. Like
you have a
T-stage.
kidney sitting. Yeah, you have a kidney sitting right next to it. You have the liver lower end seen there. Whether there is anything infiltrating that. All those things are extremely important. So when you describe CT, it doesn't go by saying there's a thickening in the ascending colon. You describe all these things, whether it's positive or negative. That basically tells the examiner you already looked at it umpteen number of times and you know how to look at a CT. All right. So you got the CT now. What is the next step?
Sorry, sir.
What is the next step?
Sir,
you got this CT.
Sir, now I'll proceed with with the CT findings. Now I will proceed with the colonoscopy and then biopsy to prove the diagnosis.
Okay. Sanju.
So what was the colonoscopy finding?
Sir, colonoscopy showed an irregular proliferative growth in the hepatic flexure with significant luminal narrowing, and the scope couldn't be advanced beyond.
Okay. Okay.
Oh, let me just say this patient had a few nodules, a few adenomas. Okay. So how do you approach that?
Sir, adenoma.
You suspected this was a SAP, right? Or whatever, some sort of a family history was there.
It should be it should undergo endoscopic resection.
Endoscopic resection.
Yes, sir.
So what constitutes a malignant polyp? What do you call a malignant polyp? we know we will go to that big marks later. If this patient has a family history and definitely has some polyposis, what would you call a malignant polyp?
Sir, like if the carcinoma is involving submucosa.
If the carcinoma is involving submucosa, if it's not involving the submucosa,
then it is in situ.
It will be an in situ. Right. So now you have gone and taken a biopsy from the main lesion. What do you want to do now?
So, after polypectomy, I will look for the high risk features.
Okay.
In the pathology specimen. Sir, for if it is a pedungulated polyp with no high risk features, that high risk features include grade 2 or 3 or lymphovascular invasion or margin positivity. If none of these are there, then if it is pedungulated, then I will keep the patient on follow-up only.
Okay. All right. So you did a biopsy from the main lesion and then you sent it to the pathologist. You got a report saying motility differentiated adenocarcinoma. Is there any other pathology that you can expect other than adenocarcinoma? Are there any other diagnosis possible other than a conventional adenocarcinoma in the colon?
Sir, lymphoma, GIST.
Okay. What is the most common site of GIST? Tell me the percentage of GIST in different sites in the GI.
Small intestine.
Percentage.
Percentage, I don't know.
If it's lymphoma, what lymphoma?
NHL. Sir, malt lymphoma.
Sanju?
Anthony, which histology will be common in a right-sided, somebody with a right-sided colon lesion? Which lymphoma? Is it malt lymphoma? Are you sure? Which is the most common site of malt lymphoma in GIT? Where do you get mantle? Where do you get diffuse large B-cell lymphoma? The most common site of malt lymphoma.
It's in stomach, sir.
Yeah. So diffuse large B-cell lymphoma will be more common there. So okay.
Yes,
so how will you stage this patient? Now you have done the CT, you have done the colonoscopy, you know that there is a tumor, you did a biopsy. What next?
Sir, by this time I would have also done tests for assessing the fitness of the patient for treatment also. That includes CB hemogram and then biochemistry test also. If the patient is going to tolerate the treatment.
Okay, just hold on. Before we go into that, just go back to pathology. And what are the information that you're looking for in the patient's biopsy report? What are the important information that you look for in the patient's report? Is moderately differentiated adenocarcinoma sufficient for you? Is that all that you need, or do you need something more?
Sir, grade, the lymphatic invasion, vascular invasion, perineural invasion, perineural invasion, then then the number of lymph nodes, tumor budding, margins,
Margins. You've
Yes,
not
sir.
done a surgery. You're talking about polypectomy. Yeah?
Oh,
You're still on the polypectomy page in NCCN.
sir.
You have the NCCN open in front of you.
No, sir.
Seriously? We can
I
pick
thought
up.
like, so like
Anthony, we can pick
How
up.
did you identify that, Wesley?
This is the third eye which I don't tell people. We are not there. We are not on the malignant polyp, Anthony. We are talking about the biopsy report that we have got. In the pathology, what are the important, significant features that you're going to look at, which will help you decide on what's the next thing to do?
Sir, like you're talking about the polyp.
Yeah. We're
Sir,
not talking about the polyp. I'm talking about your ascending colon mass. Polyp we have left. Because polyp you answered very crisply, so I knew it had come from the NCCN.
Okay.
Okay, so tell me.
Sir, from a biopsy specimen, like I'll be looking for
Okay, what is the pitfall of biopsies in colon? This is just a common clinic situation. You have a patient whom you send for colonoscopy, he comes back with the report, which is nothing seen. What do you do? Face it, you have had patients who have come with a biopsy report which doesn't show anything, or it's a very superficial mucosal biopsy. They do that. They do not comment much on it. They say superficial biopsy, kindly repeat. What do you do?
To repeat the biopsy.
You have to repeat the biopsy. Again, another colonoscopy.
Multiple.
It's a practical question. It's just a practical question. We all probably deal with it in different ways, but it's just a practical question. I have come across enough number of times when the pathology result says nothing seen, please repeat. For a pathologist to say repeat is easy. For you to convince your patient to go back with another colonoscopy is horrendous. He'll kill you.
Multiple course will be taken during biopsy.
Ideally a biopsy. That's not possible. Anything else?
No, sir.
You mentioned all the blood tests possible. Is the CE relevant?
CE. Yes, sir. Yes, sir. CE is there.
When were you planning to do that?
Sir, baseline.
At baseline.
Yes, sir.
Okay. All right. Arun is saying time's up. So let's assume you did a CEA. CEA was 35, and you did a biopsy. Biopsy says moderately differentiated adenocarcinoma. What's your next step?
Sir, to proceed with surgery.
What surgery? These are all single line answers that you're giving, which invites more questions.
Sir, colectomy with en bloc resection of the lymph nodes.
En bloc resection of lymph nodes. And what do you understand by that? And what do you mean by that?
En bloc resection of the regional lymph nodes, sir.
Inguinal lymph nodes.
Regional lymph nodes.
Regional lymph nodes. Sanjay, your surgeon will allow that?
Actually, you can be more precise in your answer. We cannot say that it is colectomy and en bloc resection. There's a name for that. Right side colon, what will you do?
Hemicolectomy, sir.
So that's what he was trying to ask you. So, how will you do hemicolectomy? What procedure will you be happy with the laparoscopic procedure or an open procedure?
Sir, like in cases that present without obstruction or perforation, then we can do with both laparoscopy and the conventional open procedure at the experience centers.
Okay, so there is no difference in outcome. So,
Yes.
so Wesley, anything else? Sorry, I'm traveling.
Yeah, no problem. Thank you. Your inputs are valuable. Anthony, you've done a surgery. Let's assume you've done a surgery. We don't have time. Arun has allowed us 10 minutes. So if in case you do a surgery and the pathologist finally gives you a right hemicolectomy, the final pathology result, and it reads as moderately differentiated adenocarcinoma, T3N0 after your en bloc resection of all the lymph nodes. All right.
Yes, sir.
Now, if it's a T3N0 and you've done a staging workup shows no metastasis. What's the next thing to do? What are you going to do?
So I will see the histopathology, and
I
will.
already told you. I told you the histopathology. What are you going to do next? Patient is sitting in front of you.
Sir, I will risk stratify the patient. It's a case of stage 2. Hello, sir.
Okay.
Carry on. Carry on.
Sir, I will risk categorize the patient, whether the patient has high risk features or intermediate risk features, and then I will decide with the adjuvant treatment.
Okay. What are the high risk and the intermediate risk features?
Sir, high risk features include PT4 or cases that present with perforation.
Anthony, you've been given a situation. It is a T3N0. There is no discussion of perforation. There is discussion of nothing. You've already called it a stage 2. It's a moderately differentiated. You've been given that circumstance.
Okay.
So don't go back and change the situation. Just stick to that and tell us what are you going to do next. How are you going to do the stratify?
Sir, so lymphovascular invasion, PNI, like all are negative.
Okay.
Yes, all are negative. Yes.
All are negative, but pre-op CEA was 30. So it is an intermediate risk.
So what is the intermediate risk? What is low risk, Anthony?
If none of the risk factors are present.
So any of the risk factors, so what is intermediate risk? I'm not sure about that. Is it low risk or high risk?
I'm not sure.
Solely low risk or high risk? Any risk factor will make it high risk, but how will you come to a decision on your adjuvant treatment? This patient, Wesley's patient, is coming to you, T3N0, right-sided colon, is coming to you, 51-year-old. Is that something is ringing in your ears? What should you do next to come to a decision on your adjuvant treatment?
MSI testing.
Exactly. So you have to do MSI testing
exactly
to
answer
come
we
to
are
it.
looking for.
Sir.
Okay.
Okay.
So what does
MSI testing is done.
Include? So what does MSI testing include?
Sir?
What does MSI testing include? How do you want to do it? Are there different methods of doing it?
Yes, sir. We can do it by IHC to look for the expression of MMR proteins, or we can do it by PCR or NGS. That will look for MSI.
So, which method is commonly practiced in your institution?
IHC.
Okay. So, what are the 4 proteins which you check in your routine, MSI by IHC testing?
Sir, MLH1, MSH2, MSH6, and PMS2.
Exactly. Okay. Now, this patient, how will you say that? Suppose 4 of these proteins are checked. How will you define that this patient is having MSI high by IHC?
MSI high by IHC.
Yeah. So you are given a report of MSI high by IHC. MSI. So when will you see the? I mean, how will you define MSI high by definition? By seeing the histopathology report, immunohistochemistry report.
So that expression is lost.
Which expression?
That
you have told about 4.
Sir, MSI protein expression is lost on IHC.
How many? Okay, so how will you interpret that? So it's 1, 2, 3. How will you define?
Sir, 1.
All 4 lost. Is it possible? Which is the most common one lost in expression?
Sir, MLH1.
Exactly. Now, this patient, 51-year-old, suppose this patient's MLH1 is lost. So what is your what is the implication? Because time is not there, I'm just rushing through questions.
Wesley, sorry, MLH1 is
should be rapid fire.
Sir, MLH1 is lost. I will also look for BRAF mutation and somatic.
Anthony, hold it there. Hold it there. You have a MLH1 lost. You have got somebody who is probably MSI high. For this patient, what is the implication? What are you going to interpret that data into patient further management? That is a question.
If MSI is high, then I will keep the patient on follow-up.
Why would that be?
Okay.
Because there is no the benefit with chemotherapy in stage 2 with intermediate risk MSI high, it is dismal only.
Please go and read this intermediate risk. That's confusing all of us. We also don't know what intermediate risk is. Anyway, Sanju.
So, Anthony, Dr. Wesley was telling you about pre-op CA levels of more than 30. Suppose patient has pre-op CA of 30. Patient had some obstruction and MSI is coming high. How will you define? How will you, come to a conclusion?
Sir, then patient automatically comes into high risk.
Okay. So, you then why should we do MSI high here? You have already defined that this patient is high risk.
Sir, you didn't mean
the pre-op CA is 30.
Sir.
There was some obstruction. MSI is high.
Sir, then multiple risk factors are there. Then it will come to high risk.
So, okay. So, but it's not like that. So, MSI high, if it is there, then you need to discuss with the patient, because nobody knows whether this patient is really high risk or not, because MSI high is something which is the most important finding. But let me ask you this: suppose you are defining that this patient is high risk, how will you define? How will you treat this patient?
Sir, this is as per ESMO protocol, which is being followed at our institute.
Okay.
So, sir, for high risk, actually, we'll take into consideration, like if it is a pathological T4 or less than 12 lymph nodes are assessed, or if multiple intermediate risk factors are there. Then, even if it is MSI or MSS stable, then we'll treat the patient with adjuvant treatment, like 6 cycles of Folfox or 6 months of Folfox or Capox.
Wesley?
Yeah, it does make sense in what he's saying, but he's putting it in a different perspective. It's okay, Anthony, what you said is right. The concern about a patient with high-risk features, especially you said less than 12 nodes, that is a surgical concern, right? When it's a inappropriate surgery or a surgery which is not complete, definitely you would not consider it as a T2. I'm talking about your institution having done a T3 and 0 sufficient resection. In that case, you will only look at MSI, and if it is MSI high, you would probably avoid, unless until, like you said, there are high risk features where the CA is extremely high. You are suspicious that the patient has got micromets elsewhere, or you have a situation where there is a perforation or the patient was grossly obstructed. Definitely, you would probably add up the value by giving chemotherapy. All right, now let's say this is 30 and this patient had a oligomet in the liver. Now that makes it metastatic disease. This patient has not been operated. You did the CT scan, you found that there was a lesion in the abdomen, in the ascending colon, and then you had a large lesion about 5 centimeters in size in the liver, in the segment 6 of liver. Okay?
Okay, sir.
What would you do?
Sir, in such a case, like if R0 resection can be achieved without compromising liver function, then I can go with a single setting like a colectomy with the resection of the Mets, or I can consider neoadjuvant therapy. Neoadjuvant therapy followed by colectomy and the resection of the liver mets, followed by adjuvant therapy, and the entire perioperative adjuvant therapy for a 6 months duration.
All right. If the lesion is operable, that is what we do. If the lesion is not operable, you will want to give neoadjuvant chemotherapy. How long is the neoadjuvant chemotherapy, and what drug would you use?
Sir, Folfox or Capox is preferred.
How long would you use?
Sir, perioperative adjuvant therapy duration is 6 months.
When would you send this patient to the surgeon?
Sir, every 2 months. So every 2 months I will reassess, and then as early as possible, like when it comes like it is operable, then I will send it for the surgeon.
Sanju?
Anthony, can you tell me about the dosages of Folfox?
Sir, oxaliplatin 85 milligram per. Sir, Folfox, M-Folfox 6 that is being practiced here. I will. Shall
Okay, done. M446.
Sir, oxaliplatin 85 mg per meter square, calcium leucovorin 400 mg per meter square, and then 5-FU that is bolus 400 mg per meter square, and 4 to 6 hour infusion that is 2.4 gram per meter square or 4 to 6 hours.
Okay, so what is the difference between Folfox 6 and 7? What is the difference between Folfox 4 and 6?
Folfox. Sorry, sir. No.
Okay. So one thing to remember whenever you talk, whenever you're asked the question of the regimen, irrespective of which disease they're talking about, always start off by saying this particular regimen is a high emetic risk, intermediate emetic risk, or low emetic risk. This is what I would give. This is the infusion I would give, the prehydration I would give, post-hydration I would give. Whether you're going to use a triple antiemetic or a quadruple antiemetic, what are the recommendations once the patient has completed his chemotherapy and gone home. So these are all things which should just come. It should not be something that's constantly asked. When you say what is the chemotherapy regimen you will do, you would mention all this. These are good habits to get in so that see, now you realize this in 45-50 minutes that we have spoken. We have barely reached a point where we are just started on adjuvant. We haven't really gone beyond that. We haven't talked about second line. We haven't talked about other things. It can go on for a long time. If your entire thing that we discussed in the beginning could be shrunken to about 10 to 12 minutes, that is what you should aim for. If your entire history, clinical examination, your differentials, everything is said so quickly and rapidly that this all finishes in about 10 to 12 minutes. You've got 30 minutes to discuss all the latest stuff that you have read. You understand? Which means if nobody stops in the first 20 minutes and you clear off all the simple questions like what is the significance of weight loss, prognostic predictive factors, those simple questions that were asked, ballotability, your differential diagnosis, you bypass that and you don't get questions, you've already passed. Then whatever you say later and you bundle up also, it doesn't really matter because then those are brownie points. You get it?
Yes, sir.
All right. Sanju, your conclusion remarks?
Nothing, Wesley. Nothing from my side.
All right. Anthony, that was a reasonable presentation. It can be improved upon significantly. And probably if you pay attention to how you take the history, start thinking of how you're going to conclude and how you're going to approach this case. Examiners want you to want to see only how you approach the case. They're not interested in knowing whether you know everything about lymphoma or about colon cancer. Nobody passes you because you know everything about it. All right. If you know how to approach the case well, then that's sufficient, and be comprehensive. Don't just have your mind set on some one diagnosis and then revolve around it. Then you get stuck. Arun, over to you. Thank you so much for allowing me to be here.
Yeah, thank you so much to examiners. I think, yeah, we've spent quite a good lot of time. There were, easy questions. There were tough questions also. So good work by Dr. Anthony as well. This week's meeting on the Journal Club will be postponed to next session next month because there's a lack of time. We don't want to keep people waiting for too long. We had a good attendance, almost 60 participants were there. So I hope, we keep learning. And thank you so much again. Bobbin sir, if you're there for the closing remarks. Okay, I think Dr. Bobbin is busy. So yeah, that's it from Ampok. We'll see everyone again next month with a different case presentation. The Journal Club will remain the same.
Yeah.
Yes, sir, close remarks.
Because of some, yeah. It was a very good case discussion which we had today. Especially as an examiner, it's going to be a very tough job for. It's going to be really tough for the postgraduates. But then there's a very good learning experience for them. So I'm happy that we are able to have this meeting. But then the journal got delayed for some unforeseen reason. So that's okay. We'll have that meeting next time. Okay. Thank you all, and we'll catch you up next month. Bye. Arun, bye. See you all.